I'm going to ask two questions of each of our guests, and then having a little bit of a moderate conversation. And then we're going to open up the floor for you folks again to ask some questions of our guests. And if we have time, there might be a third sort of parting volley of questions we'll share back with each of them. So, Asra'a, Paulina, and Gaynor, I just want to let you know that you are here with 35 Nova Scotia residents, all of whom are volunteering their time to think about how to make primary care in this province better for all. And I think it's that idea of better for all where I'd like us to start. So if you would each kind of tell us a little bit from your own professional and personal perspectives, why equity in primary care is important, and share a couple of the key challenges faced by patients or providers as they try and navigate the system. So in what ways is the system not equitable at the moment? Asra'a, if we can maybe start with you, Paulina, and then Gaynor, follow up with you.
All right. Hello, everybody. Thank you for having me. That's a big question, but I will try to be succinct because I want to give people the opportunity to ask questions. So to me, why it's important, to me seems very like a basic human right, that we should all be treated equally and equitably. I as a Canadian, I feel like that's just intuitive, that there should be equality and equity in things that a Canadian has the right to, and differences between Canadians just kind of flies in the face of our values. But for those who are less into that argument, I will say, it just financially doesn't make any sense to not be. It's bad for the entire group when we treat some inequitably. So I have a child on the autism spectrum, so not supporting a child who's on the autism spectrum to develop as equitably as possible, it hurts the system, because then they grow to be adults that can no longer develop things that they could have as children. And that's actually bad for the system and bad for the individual, because now they are more dependent on other people, and therefore the system has to provide for them with that dependence. And this is true for almost any issue that you can talk about, that, you know, an ounce of prevention is worth God knows how much in an emergency situation. So I think that is intuitively and even financially, like that entire spectrum, it's important in all cases. And I disagree strongly with the notion that it's costly to do. In the end, it actually is not. But doing it while we have an emergency system, it initially might be a little bit more of an upfront cost. In terms of the issues for providers and for patients, there are many. I will try to just kind of give overall thoughts on a few things. So for providers, lack of education, lack of training, and a lack of a proper compensation that allows you to provide the care properly, while having to balance your other responsibilities. So at the Newcomer Clinic, recognizing that these are patients that require more time, because newcomers have often a language barrier, a cultural barrier, don't know how things function in a different country, in a different language, in a different way of thinking, and then ability to access care, because they just physically don't know that address because they're not from here. So they, as a default, the smallest appointment they give is a half hour long. I don't know of any other clinic, and I've worked in many, that is paid in a fee-for-service model, and the model that most doctors are paid, that would do that. But they need it, because if you would normally give a 15-minute appointment and everything must be translated, basic math will tell you you need double the time. So the models of care is one of the issues. I practice share. I'm going to be practice sharing with a physician who is much more efficient than I am as a physician. But that means all the mental health stuff that requires more time, patients just naturally gravitate towards me. So I'm going to get paid less for doing the same amount of effort because I'm seeing fewer people. Again, the compensation model doesn't work, and it means that equity, equity deserving underserved communities are more likely to be disadvantaged. A lot of the issues are issues for everybody, but it just hurts more for those that need it. So I always say about my son, he's the last to be included and the first to be left out. He's on the autism spectrum, is 8 years old and just learning to talk. So that's kind of the pattern for underserved communities. Another big problem is the siloed care. This is a problem for everybody because patients don't know how to access other things if they're not walked through it or have someone to help them navigate. And physicians sometimes have issues with accessing certain things because everything is so siloed and they don't know this is happening. They don't know how to get it or how to get the other team to understand what it is that they need. Access to care, I've kind of already alluded to, just knowing where things are, getting the transport to get there, having a language barrier, having a cultural barrier, needing to be able to read if you are not literate or not literate in English, needing internet if you don't have access. You know, now appointments are booked online. It's okay, so what if I can't access online? What if I can't read it to access it online? And then another big peeve of mine is that if you're in a low socioeconomic status or a refugee or whatever the case may be, drugs are covered, but other things are not. And a lot of the care that we need is not drugs. It is a physiotherapist, it's a behavioral therapist, it's a human being. It is alternative medicine, which I don't really like because it means somehow it's not medicine, but it is not drugs. And we are very, very poor at covering health that is not drugs, but it is so much of healthcare, and so much of what would help the social determinants of health. So those to me are kind of the big overarching issues in terms of siloed care, models of payment and compensation, access to care, and then coverage for things that aren't kind of the classic in a hospital or drugs for treatments.
Amazing. Thank you, Asra'a. Okay, Paulina, from your perspectives.
Thanks, Asra'a. I think that honestly, I know I'm speaking here specifically from the point of view as an Indigenous woman working in Indigenous community. And luckily, I mean, I am Mi'kmaq and most of the community we serve is Mi'kmaq, but the thing that makes it really difficult for us is we don't fall into a lot of spaces that qualify for funding from the province or the federal government, because we're in a space where we're serving an urban Indigenous community, which is not recognized as an official Indigenous community because we don't live in the Indian Act enforced reservation system. So because we choose to live and work off reserve, we're penalized by government systems where we don't receive the proper funding. Like, for example, we were fighting with two of our partners that were supposed to come through for this fiscal year. So their funding should have been in for May 1st. We just got confirmation 2 days ago that it's coming soon. So we've been running on empty, running our clinic through funds that are not meant to fund the clinic and that are supposed to go to other community services. And this is a constant battle for us. So, you know, and that trickles down in a very difficult way for our patients. Like, we're really trying to not let it right now. But that's just the reality of it. The bureaucracy around healthcare makes it so inaccessible for so many people. It's not just us. Like, I see it on a greater scale because I'm dealing with just Indigenous patients and just Indigenous families. But I see it everywhere. I also have a lot of background as an emergency nurse. And that's what I saw a lot in emergency. We saw people coming in for primary care needs because they just cannot access it, whether it be the socioeconomic barriers that they can't get to a doctor's office, or they try and go to a walk-in 4 times that week. And every day that they get there, even if they're there half an hour before opening, they can't get in. There just isn't access. And for me, I think, you know, one of the biggest things that gets me, and Asra'a had said, about how they have the minimum appointments. I think that is such a beautiful thing in terms of equitable care, you know, because equal care doesn't work. Not everybody has the same needs, even within certain populations. Like, you know, I work in Indigenous community. A lot of our patients, you know, live fairly, like what is seen as fairly normal lives. For people, you know, they're not addicted, they're not struggling, they just need doctor care. Then we have people who are. We also have pregnant patients. Like, we have a wide population, so not everybody has the same needs. So we also do a model where we do a 30-minute minimum for every single appointment. Phone appointments are usually 15, unless it sounds like it's something more complex, then we do a 30-minute. We also do a nurse triage system where we have same-day appointments open all the time, where either me or my partner at RN will discuss with the patient and decide, you know, kind of based on, both of us worked in Emerge, so we sort of use the CTAS score to decide whether it's appropriate that someone needs to come today, that they can wait for their next appointment, or if they should be advised to go to emergency. And we always do that. We always leave the last 30-minute appointment open every single day for our family physicians, so that we have something if people need immediate care, to sort of curb that wave of primary care needs away from emergency rooms, because honestly, that's the only way people are accessing. So it's really hard. To me, that's like the biggest barrier I see, is we just don't have the supports, period. You know, and family physicians, unfortunately, pay the most for being in their profession. And they're the people who go into medicine to take care of people. They do it, you know, for the heart of it. I personally don't know family physicians that come in and say, it's for the money. You know, definitely not the specialty that makes you, you know, a billionaire. So they pay the highest in fees, they pay the highest in overheads, they pay back so much more than any other specialty. But then as a whole, we complain that we don't have people and it's not a desirable job. And it's because some people can't afford to. They literally cannot afford to be family physicians, to take care of their own families, because they have to pay so much more than other specialties. And, you know, that's been a big thing for us recently in trying to get our funding and saying, like, you know, we need these overhead subsidized for our family physicians, because they're already doing so much. And they're already paying this huge percentage of their salary back. And, you know, we can't afford to have them being paid so little. So and we don't do like a pay for service model. We have like kind of a flat, like a flat wage for our physicians, but still, you know, it gets really difficult that way. Especially like say, and pay per service like Emerge, I have docs that will fly through 30 patients in an hour. So, you know, you can see that how that causes a huge wage discrepancy. So for me, that's really, I think, probably one of the biggest things, is that we need to make our primary care model better for everybody, and starting with our service providers, because if they're treated properly, we have more service providers, all Nova Scotians are going to benefit from that. And it has a great trickle down effect.
Okay, thank you for that, Paulina. All right, Gaynor, what would you like?
Thanks. I'm hoping everybody can hear me okay.
Yes.
Great. So lovely to be here. And I'm really happy to be following on Asra'a and Paulina, because I think they made some fantastic comments. I'm going to back up a little bit and also introduce that I've just come from 3 days of a systems change conference here in Nova Scotia. So I'm going to bring some insights from that conference as well into this conversation, in the event that it helps the work that this group is doing. But I want to come back to your first question, Jasmin, around why is equity important, and just remind us, and this is, I'm gathering that the group already got this orientation to the difference between equal versus equitable, but just remind us that we worry about equity because it represents not just differences in outcomes or differences in access, but modifiable differences. If these conditions over here had been satisfied to begin with, the difference wouldn't exist. That's the modifiable part. And then therefore unfair, right? So we didn't modify these things, we left them in place. This has resulted in an unfair difference in access or in outcomes between Group A and Group B. That's why we worry about equity, is because equity represents an unfairness inherently that we don't think should be there. And so what we go for is kind of justice-oriented approach to accessibility and to getting health outcomes in the healthcare system. And so your first two slides, Jasmin, I think are really important. And I would actually take us back to the Canada Health Act just for a minute, because I recently had the opportunity to spend some time on a different panel presentation with Greg Marshallden, who is the co-author of a book with Dalhousie's own Catherine Philbeck from Political Science, on the Canadian Medicare Act and sort of the flaws of that act. And so Greg Marshallden and Catherine Philbeck. And what he described and for those of you who don't know Dr. Marshallden, he's from University of Toronto. He is a lawyer and former Deputy Minister of Health, and is kind of one of these people who's been everywhere and done everything. And so as I'm listening to this presentation on the Healthcare Act, I'm a little shocked that he's at Dalhousie University, St. John campus, telling us about this instead of screaming it from the rooftops to all the decision makers that be. Because his assessment was, and I would tend to agree with it, that the Health Act, A, is completely outdated for the complexities of modern practice and the complexities of modern community, modern patient needs. And B, was never designed to deliver on the flowery promises that are in the preamble to that act. And those promises, most Canadians recognize. This is the promise of universality and portability and accessibility and all of those things. And so what he goes on to describe is that in the meat of the act itself, there are no mechanisms to provide those things that we all believe we're getting as consumers of the healthcare system. And so not only is the Health Act shallow and outdated, but he goes on to say that the inequities are, as you pointed out, Jasmin, baked into the Canadian system in a way that we can't reverse unless we reverse some of those pieces of legislation. So Pauline has already spoken to the plight of urban Indigenous populations in Canada. I think that's a great example, who are not covered by the Canada Health Act. Refugees are not covered by the Canada Health Act. Interestingly, the Harper government, he points out, actually made the decision to put the RCMP into the act while they were in government. They had previously sort of existed within their own kind of workplace health program. They were added in as beneficiaries of the Canada Health Act during the Harper government time. That was a deliberate choice. And it's an interesting one when you think about who I've already described remains left out of coverage by the Canada Health Act. And so those decisions are political and continue to be political and speak to the values around who do we value enough to make sure they have equitable access under that act, as flawed as it is, and who do we undervalue in that. There's also another point that he made that I'll bring out before I move to the next piece, which is that in addition to the acts that you've mentioned, Paulina, the Indian Act, the Canada Health Act, we also have workers' compensation in Canada, which in most provinces and territories actually represents a Cadillac care system. And so we talk as though two-tiered healthcare doesn't exist and should never exist in Canada, but by virtue of having workers' comp, it actually does. That is co-funded by the public system and privately through employers. And the access that employees get through workers' comp is uniformly across the country superior to the access that is gotten by folks outside of the workers' comp system. And so you start to see how deep the flaws in equitable access are in the Canadian landscape. And I just want to point this out for this committee and whatever voice you can give to that as you do your work. So there's that. We had the pleasure at our conference here at Dalhousie over the past 3 days of hearing from several political leaders, 2 former premiers and a former minister of health here from the province of Scotia, as well as some health system leaders from Nova Scotia Health Authority and actually Sharon Rutherham from the Mi'kmaq Health Authority. Just talking about, sort of the health system policy challenges that they face in trying to move things like equitable access forward. A couple of things stood out for that I would point to your attention as well. Maureen McDonald was on the panel and spoke to this idea that the saving of money is almost never a priority consideration for government, because what they see is the cost of implementation, which is the first cost before you get to the money saving. And so they never get past cost of implementation, was her read on things. And as we think about how we might look for policy solutions that improve equitable access, I thought that was a really insightful offering from her, because there's a way in which we would need to convince governments, and I think we can, that actually the upfront cost does, and when you run it out, produce those savings long term. They would have to tangibly be able to see that and believe it before they would buy in. And she was very much making the comment that they can't see past the implementation cost.
Yeah.
Daryl Dexter, who's a former premier of the province, was talking about sort of what those policy solutions then might look like if you can get past that implementation cost. And what he described was, and I think this is accurate, and I'll tell you why in a moment, what he described was that people are always looking for the silver bullet. And he said, there's no silver bullet, there's only silver buckshot. You have to throw out a number of policy solutions in order to get it right. And here's why I think that's so important when we're talking about equitable access. There is no way, with the complexity of the Canadian public, of the Nova Scotian public, that a monolithic, monochromatic approach to healthcare delivery is ever going to fit for everybody. And we have this notion that if we put it all into one act, if we put it all into one health authority, if we put it all into one structure, it'll work for everybody. And I think you've already heard from Asra'a and from Paulina all the ways in which it's never going to work for everybody, because it necessarily has to be as complex and multifaceted as we are as communities if it's going to meet us where we are. And that challenges our notions of how we do bureaucratic decision-making and how we do bureaucratic policy-making. We like things to be, tidy. We like them to rest all in one place where we can see them, tinker with them when we need to. And our conference was about complex adaptive systems, and we're starting to recognize just how much the healthcare system is a complex adaptive system, and how our even mental models of what that looks like need to change. And so I'm challenging this panel to step into a space of how do we create a primary healthcare system that actually truly reflects the complexity and multifaceted nature of who we are as Nova Scotia communities, and that might mean that we need almost a solution for every individual configuration of community, knowing that that might create redundancies that we hadn't anticipated. But it may not be the solution, but I would challenge you to at least think about whether or not that's an appropriate solution. And part of the reason I say that, and I'll end on this note, is this. I had a conversation with a colleague of mine who works with us in the Faculty of Medicine at Dalhousie. She's actually from the School of Social Work. And we've brought her on as our second visiting scholar for equity, diversity, and inclusion, is what we call the position. And so this is Dr. Eli Manning. And when she first came to the Faculty of Medicine, she looked around and she said, so you people in medicine have a really interesting conceptualization of the model patient. And I thought, this is going to be really good because she's quite insightful. I said, nope, so you have to tell me. And what she said was, well, in social work, when we think about the model patient, we think about who are the people who are coming through the door that we have to model our services for. And we know that we are going to see newcomers, and we are going to see refugees, and we are going to see single moms. And she went through a list. So we model our services to do that. And I started chuckling because I said, we don't have that in medicine. We literally have what we call the 70 kilogram man. The 70 kilogram man is a tool that we use to teach medical students in particular about pathology and pathophysiology. And what we say is, if you understand it in a 70 kilogram man as the reference human, and when that term first was developed in the 1970s, it was meant to describe the reference human. So we say, if you can understand it in a 70 kilogram man, you can understand it in everybody. Pediatricians immediately go, that does not work in pediatrics at all, because nobody is a 70 kilogram man in pediatrics, right? But you start to see all kinds of ways in which it doesn't work. And so as Dr. Manning was figuring this out, she finally looked at me and she said, does anybody in medicine only ever see 70 kilogram? Because by the way, what it also means 70 kilogram white, able-bodied, hetero, cis, gendered men, right? And so she said, Does anybody in medicine only ever see 70-kilogram white able-bodied cis hetero men? And then we both burst out laughing because we were like, of course not. And then she said, those are the people who wear the coats, but they're not the patients who are coming in the door, right? And so I guess that would be my final point, is that we're starting to recognize the ways in which, if we want an equitable system, we actually have to design it for the people who really need it. And that might be far more complex than we had ever envisioned before. It is certainly more than designing it for the stereotypical 70-kilogram man. So I'll leave it there.
Thank you. All right, Gaynor, thank you. So much to think about. All three have all given us so much to think about. And I actually just want to pick up kind of on your last point, Gaynor, and help us use that last point to pivot to kind of, I would love to get your thoughts from all three of you on like some of the solutions. I mean, we've started to talk in broad strokes and heard some pieces, but would like you now to like really just speak quite succinctly to what are some ways that we could be thinking about designing a system that is as complex as the needs of the Nova Scotian public. And it's that idea of kind of the model patient. And Asra'a, I saw your head like nodding furiously, because I know during our prep call, you one of the things you brought up that you wanted to touch on was the idea of the model patient and how this doesn't work, and how our systems need to be designed to actually really work with the patients that we have. And so would love for you to kick us off with that, Paulina, and then Gaynor will give you the last word. And then folks, we will open it up to questions. Yeah, please go ahead, Asra'a.
So solutions, wow. Okay, so people always say, oh, we've got to talk about the models of compensation and that kind of thing. And the thing for me is that, A, good luck dictating to all physicians to just follow one model. It's the same thing as like good luck having one model that fits all patients. It's not going to happen. And I like, for me, I love it. And when I see, oh, like the Newcomer Clinic, they have things organized this way, and Dal Family Med have things organized this way. And they're like, oh no, it's great. We do this. And I'm there as a locum. So I'm there temporarily. And I'm like, that's nice for you. I still see these patients when I'm not in this clinic, and I don't have these resources to be able to see them. And I don't have these supports to be able to see them. And I can't provide the same quality of the care because I am not in a specialized clinic that allows me to do that. And there are not ways for me to bill or get compensated to do it outside of this specialized model. Like they have, they've added, this is very more recent years, a fee that you can charge if you use an official translator. It doesn't double my pay for that visit, even though I have to use double the time at a minimum to do the visit. So it's inadequate in its compensation and illogical. So there are types of things that you can do, but that is part of it, is that it has to make sense. So I've seen in other places where, for example, and this is obstetrics, unfortunately not in Nova Scotia, but in BC, where not all deliveries are paid the same. So a delivery with a patient with this complication, you add this modifier, you add that modifier. And so that you can actually get something that should be reflective of the difficulty of this scenario. I know in the territories I've heard of, you get paid per issue as opposed to per appointment. So if you come in and I dealt with 5 issues, I don't get paid the same thing as dealing with 1 issue. And when you have a problem just getting to my office, this whole 1 appointment, 1 issue thing doesn't fly. So for doctors in underserved communities, that they never have this policy. And doctors in like downtown Halifax, which by the way is where my shared practice is, so I see the whole spectrum of patients, with really well-off patients that will come in like every day if you ask them to. You know, you make so much more money for doing the exact same care, because the patient will just keep coming in and you don't have to take a half hour. You can take 5, 10, 15-minute intervals and see them multiple times. So there's so much about inequity that is just with the payment model. And then the siloed care that we talked about, the team-based care that we talk about, some of these things have started to be put into place. So physician-to-physician consults have now become something that you can do, but they always audit you, want to try not to pay you for it, all of the and put all kinds of rules so that you can call the physician, ask for advice, do what's best for the patient, and then not be compensated, even though it's under the name of you're going to be compensated. And again, covering things that are not drugs, covering that to me is a huge thing. One of the biggest things that I think would be lovely to have are patient navigators, because the system has to have lots of different solutions. And in the end, it's going to be confusing to people where to go where. So if somebody has a navigator that can say, oh, you can get this here, and you can get that here, and you can get this here, and they connect you because their job is just to know the system. And you can have navigators for cancer, you can have navigators for newcomers, you can have and they can also act as cultural translators, because there's a lot of issues with culture being an issue. So we have a friend, this is personal life, not professional life, who has a daughter on the spectrum. The family is originally from Iraq, here as refugees. And when the dad, knowing that his daughter is on the autism spectrum, registered her for school, did not tell the school that she was autistic so that supports could be put in place, because where he comes from, the school can say, cool, we're not going to take your daughter, she can't go to school. And so he thought, well, I'm not going to tell them because I don't want them to say that they're not going to accept my daughter in the school, not knowing that's illegal here. Public school can't say that they won't take your child because they're on the autism spectrum. So there's just barriers. In other countries, you can go direct to specialists. So there are barriers that a cultural navigator or healthcare navigator can help. And when I see really great translators, they do that. They say, oh, no, here you have to go to the family doctor to get that. You have to, so that I think, because I've heard of it being used in things like breast cancer, where you might be seeing lots of different specialists. There are so many things where that would be helpful. I would love to pieces if there was an autism navigator. I always tell people when they say, what do you need? I'm like, I need a mom who has an autistic child, because she'll be able to tell me. Basically, I'm telling you, I need a navigator. I need somebody who's already done this that can tell me how to navigate the system. It doesn't come from the doctor. It doesn't come from the physiotherapist. It doesn't come from this one. It comes from somebody who knows this system. And so that for me is a huge thing we don't have that we could put in that could actually encapsulate solutions for many things, because they can act as the connection that we might otherwise have gaps for. So I'm just going to leave it at that.
Beautiful. Thank you. And Paulina, so in the chat, you're sharing that you're working on hiring Indigenous health navigators as well. And so what else is going on to make access to care better for the Indigenous folks? Yeah.
There's a lot of things going on. I think I know in our pre-discussions, I wanted to sort of talk about a couple things that I think members of this panel should look into on their own, because even if I had a whole hour for just me to speak, I couldn't touch on all of them.
Fair.
But I think it's really important, and I'll get Jasmin, maybe if she doesn't have all the links, I'll send them to her so you guys can do some personal research. But there has been a lot of work very recently within the Canadian government to really ask Indigenous people, what are we doing wrong? And what can we do better? And so there are two major reports that were put together in conjunction with the Truth and Reconciliation Commission and Murder and Missing Indigenous Women and Girls. The TRCC calls to action, specifically numbers 18 to 24, deal with healthcare calls to action about things that we can do, actionable items as Canadians, as all of us, to improve healthcare outcomes for Indigenous peoples. And for me, I really think it comes down to that model, and we're talking about equitable care. If we take care of our people at home, our first peoples, we can better care for the rest of our people. And so I feel like a lot of times we get left behind as Indigenous people because there is such a terrible historical relationship there. Not to say that things are better. They are better now and improving every day. I see it a lot in healthcare, which I love. but they are still there. And I think a big hurdle for a lot of people working in Indigenous communities, they don't see, we're missing this A to B piece of this, like we're focusing on a B2C sort of thing about building trust and relationships and then providing good care. But for Indigenous people and also some, newcomers and Black communities as well, like people with historical trauma within healthcare systems, we're missing this A to B piece, which is about repairing the relationship first. We can't expect trust from our patients unless we repair the mistrust. And that happens to anyone who's had medical trauma. So that's where the equity part is, right? Like we really need to serve people and meet them where they are. Because even within our own communities, there are different traumas and different things, but there is a big community-wide mistrust of medical systems and medical practitioners. So I think the TRCC calls to action, it's at 18 to 24. The Murdered and Missing Indigenous Women Girls calls for justice. There is a health and wellness section 3, and for health and wellness providers in section 7. And then the Native Women's Association of Canada has an action plan that goes along with the calls for justice that actually talks about actionable items and things that we can do. Because unfortunately, although it's been years since these came out, very few of them have had any action. It feels like it was just a lot of words and now nobody's doing anything with it. So I really implore you guys to try to do something with it, even if it's just to read and understand where those inequities come from and why they're there and the history of them, to sort of understand why and how we can start sort of moving forward from that and building better models that are adaptable to the very, very diverse populations we have in Canada. And then 2 other really important cases I really also wanted to ask you guys to sort of look into and figure, see the principles that came out of them. So there is actually legislation that has changed in Canada because of these 2 very specific health-related acts of racism towards Indigenous people in Canada. And the first one is one that you guys have probably, most of you might have heard of, especially if you do community work, is Jordan's Principle. Jordan Anderson was a little boy who had Carrie Feynman-Zitter syndrome. And he was from Norway House Cree Nation and was treated in Winnipeg, Manitoba, at the Children's Hospital. And Jordan had, at 2 years old, was cleared. He spent the first 2 years of his life in hospital. At 2, was cleared to be able to go home on home supports and live out his life at home. But the provincial government wouldn't cover the costs and the federal government wouldn't cover the costs. And because of that bureaucratic stalemate, Jordan spent the last 3 years of his life in hospital when he could have been home in community with community supports, with ceremony and tradition and his family. And he died in hospital at 5 years old because no one would take responsibility. So because of Jordan's death, now we have a piece in Canadian legislation called Jordan's Principle that is a child's first needs-based system that allows equitable access to all government-funded programs for Indigenous children. And the second one, I know, I'm sorry, I feel like I'm talking a whole lot, but the second one I want to touch on too is Joyce's Principle. And this is a much more recent one. This happened sort of in the height of the pandemic. So I feel like there were a lot of eyes on it because we were all at home watching. But Joyce Echaquan died in a hospital in Quebec due to the inaction and blatantly racist actions of the emergency room staff there. She was 37 years old. She died September 28th, 2020. And the only reason it came out is because she had recorded on her phone her care. And the staff around her, were talking about her as an addict, saying she was a sex worker. And honestly, even if those things were true, it did not mean she deserved inferior care. It doesn't matter. But they use that as justification that she didn't deserve care. She tried to tell them that she had an allergy to morphine. She wasn't listened to. She was given morphine anyway, and she ended up dying in the ICU in that hospital from pulmonary edema. And so Joyce's principle is another new one that is being pushed for. Quebec actually recently denied it and said, no, we don't want to put that in because that's the province where it happened. But, you know, it is one that is also coming and changing, hopefully. And the biggest hope with Joyce's principle is that healthcare providers get culturally humble and culturally safe training on the Indigenous people in the areas they work in. So here in Nova Scotia, we would be talking mostly about Mi'kmaq people because traditionally we're the only First Peoples of this land, even though there's tons of other Indigenous populations that live here now. And in New Brunswick, we'd be talking Wolastoq and Mi'kmaq. Newfoundland, Labrador would be Mi'kmaq, Innu, and Inuit. So, you know, like that kind of idea that you would be getting proper care or proper education as a healthcare professional about the First Peoples in the area that you are physically practicing. I see that as something so important. And as previously mentioned too, the like complementary care stuff and coming from a holistic model. And when we talk about holistic in Indigenous health, it's actually WH instead of just the H, because a lot of people think like hippie health when they see the H one. But from an Indigenous perspective, it is treating the whole person, which is what we do in our clinic. When we do our assessments, we're not just like, how does this feel? Do you have a history of cardiac disorders? Do you have a history of mental health disorders? We ask people questions like, where do you live? Who lives with you? You know, how are you paying your rent? Do you have issues with these things? So we're doing a full social assessment as well. And so, yeah, it's to me, I think that's the thing that's been big in our clinic, and our feedback from our patients that has been so positive is that we ask about stuff like that, about, you know, how is your family doing? What is your social situation like? What are your emotional supports like? Do you guys have any community or cultural or spiritual practices that, you know, are working for you? Do you need access to these things? And so by being able to treat the person as a whole from that Indigenous perspective of physical, mental, emotional, and spiritual health, our patients have given us really fantastic feedback. So I think that even if you're not Indigenous, that having some understanding of our perspectives and our ways of knowing and being actually give a really nice worldview that kind of can benefit everybody. I think that's it.
Wonderful. Thank you. And I mean, and also thank you for the reminder that, like, so reconciliation, the first act of reconciliation that anyone as a settler can do is educate themselves and take the time to learn more. And so Paulina, thanks for sure. Share out those links and we'll pass them along. Gaynor.
Yeah, and I'll be quick because I see that the hands are already going.
Yes, we have questions.
And so I just want to, I'm not going to offer any specific solution for a number of reasons, but the primary one being that from the lens that I hold now, having moved now to this position at Dalhousie University from what was my own clinical practice, I'm spending a lot of time looking at the health system as a complex adaptive system. And so with that complexity lens in mind, I would suggest that it almost doesn't matter what policy solution you start with. And so Asra's given a few, and I think the patient navigator idea in particular in the chat got a lot of ideas. And Mr. Dexter, as I said yesterday, sort of said, it's policy buckshot. You just throw it all out there and get it done. And so both of those things are true. And I would say if you, for example, started with the patient navigator as a solution, my suggestion would be that in a complexity landscape, the opportunity that it gives you to focus on that one is to follow it wherever it goes, wherever it takes you, and it will take you into all of the other policy arenas as you go. And so the beauty of that is, in what can feel like a mind-bogglingly complex landscape, you get to focus somewhere to start. The complexity is going to increase over time as you see the offshoots of it. Oh, patient navigation is also linked to these access issues and those access issues, these other things. And policymakers hate that approach because it slows them down. But if you're going to understand the system well enough to make the policy implementation meaningful, slowing down might actually be the most important thing that happens, at least in those early stages. So my advice would be pick something. Doesn't have to be perfect, and it doesn't have to be the biggest thing. In fact, we heard from a complexity scientist, Dr. Thomas Homer Dixon, who is at Royal Roads University in BC, that sometimes it is the smallest interventions that ultimately travel out to have the biggest impact. So I would say start with something. Whatever you start with, my advice would be acknowledge that by starting with this one, you are leaving other possible solutions on the table. And you know what? It is a complex system. Other people will pick up those solutions. So there's that. But also be deliberate about looking out for, as you go, what that by implementing this solution, you have created in other arenas. So when you solve problems over here in this solution, have you unintentionally created other problems in a different part of the system? That's a complexity approach to problem solving in an environment like healthcare that I would offer this panel for what it's worth.
Thank you. I mean, so that definitely speaks to, I think from the get-go, we've tried to sort of identify how like complex trade-offs. We can't have everything. So if we choose A, that might mean we're not doing B or we're doing C in a different way. And so I think you're just speaking to that as well. It's just like the idea that we're going to choose something, there will be ripple effects. But I think also we're hearing that, like to the idea of policy buckshot, it's not maybe just about choosing one thing, but there are going to be many different things. And for the panel to perhaps be a little bold and to really think hard on what a renewed system that really does center and value equitable access and all Nova Scotians could look like.